You're listening to the Endocast, a podcast about all things endometriosis, with your hosts, Britt Thelman-Pangrel and Dr. Eric Heegard. Hey guys, it's Britt. Welcome to the Endocast. I'm so excited. It's our first episode. I've got Dr. Heegard with me, and we are ready to rock Endo 101 today, right?
I'm very excited. It's exciting to talk about this subject and to be here with you, Brett.
Oh, thanks so much. So I think in order to start this podcast off on the right foot,
Let's do it.
We should truly discuss what is endometriosis.
I think that's a good place to start. So endometriosis is, by definition, the presence of cells that are similar to but not identical to the lining of the uterus, which is called the endometrium, somewhere else.
Yeah, so wait, that's pretty key because if you Google endometriosis, which good luck spelling it the first time, but if you Google it, you're going to see that people say it's cells that are the same.
Right.
And it's not.
Right.
So that's our first, big, bold.
Yeah, similar. And so histologically, they are very similar but different.
Okay.
And so so that's an important point because that leads back, and we'll talk about this more at some point, Britt, is kind of the history of endometriosis and what people thought it was and how it happened. But the thing I want to point is that, some people, sometimes in describing it, I'll say this is ectopic endometrium, sort of. Just like an ectopic pregnancy or tubal pregnancy is, a pregnancy that's somewhere else than where it's supposed to be.
You said so many doctor words there in one sentence.
Did I really?
Yeah, ectopic and I don't even know.
Well, yeah, okay. Thank you, Brett. I'm just trying to say I was trying to go around in a circle and kind of aim at it from a different direction, but it's tissue that is somewhere else than where it's supposed to be.
And the endometrium in general is the inner lining of your uterus, correct me if I'm wrong, that normally grows and then sheds during your period.
Correct.
So how is this tissue similar, and how does it respond in your body similar when it's not in your uterus?
Well, that's where the similarities show up, which is that it does respond to the ovarian hormones of estrogen and progesterone in a similar way.
Okay.
So estrogen, it tends to be an estrogen-sensitive condition or disease, and so just like the lining of the uterus gets thicker in the presence of estrogen, the endometriosis lesions can proliferate and get thicker and more abundant in the presence of estrogen as well. And just like the lining of the uterus can get thinned out and get ready to bleed off in the presence of progesterone, endometriosis lesions can, and most of the time do, respond to progesterone in a similar way, which is it thins them out and suppresses them.
Sure. So it responds to the estrogen that the ovaries produce, but then I've heard that it can produce its own estrogen too.
Yes, that's
correct. How
correct.
does that work?
Because they're evil little demons, and so just like like bacteria that become resistant to a certain antibiotic by mutating and creating a resistance to a antibiotic. Some endometriosis lesions appear to have mutated in such a way that even if you try to shut off their estrogen, they have an aromatase, which is I know that's kind of doctory words.
It sounds like it smells good.
Yeah, doesn't it? It's a chemical that is produced actually in all our bodies that convert a hormone to another hormone.
Okay.
And so what some endometriosis cells appear to be able to do is they create their own fuel.
Yeah.
And so you try to take their estrogen.
Self-fueling beast.
Yes, exactly. So when you try to shut off their estrogen, if you try to stop the fuel, they just say, we got our own generator, and they create their own estrogen by converting other hormones to estrogen, like cholesterol. And
that's messed up,
isn't it? It's just
so
bad. Which is why some women, it's not very common, but who are menopausal, can continue to have symptoms even though if they're not on estrogen therapy or something like that. Even though they can still have symptoms because it's most likely because the endometriosis lesions are producing their own fuel.
Okay. Well,
Yeah.
that was mind-blowing.
Evil
and I
beasts.
learned a new word. What was it? Aromatase?
Aromatase.
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 I like
Let
that.
it roll off the tongue. Aromatase.
That's the word of the day, everyone. Aromatase. I like that. Okay. So
I'm Britt, and I'm here to talk about aromatase.
no, I probably will never intro things that way. Okay. So let's talk about where endo is found, because I think a common misconception is that endo is a uterine disease, meaning
Right.
it's a disease of the uterus.
Right.
And that is true or false?
It is false. And by definition, it is an extrauterine disease,
Oh.
meaning outside the uterus. Because,
Like extraterrestrial.
right, off of the tear,
Okay.
which I think is
Don't go down a
is
rabbit
it
hole.
Latin for earth or something? Tear, like terra firma?
I didn't take Latin.
I didn't either. That's why I'm just guessing. I'm probably wrong, but it sounds good. But yeah, so and you can find endometriosis anywhere in the body, and that's what's so confusing for many people is that even though most of the time, let's just say 99% of the time, you'll find it in the pelvis or the abdomen,
Okay.
but rarely, and they're almost all reportable in a sense. Is that you can find it in the lungs, they've found it in the brain, they've found it in other parts.
I heard
of
eyes.
Eyes. Yeah, that's crazy. And so it's, so it can be anywhere, and which leads to, in many cases, kind of the confusion of how does it happen there.
Right.
But so you can also have endometriosis on the uterus,
Okay.
but it's not really, and it could invade into the uterine muscle too, but it's not a disease of the uterus per se.
Because it doesn't have to just be in the uterus; it can be anywhere else.
Most of the time, it's rarely on. It's very uncommon to actually have it be uterine, and that's
Okay.
It happens a fair amount, but it's not. Again, it's not the primary area that it usually forms.
So I think the reason so many people think it's a uterine disease is because a lot of the symptoms center around your period, which is a very uterus-driven activity,
Yes, it is.
and sex,
Yeah.
which has a lot to do with your other female reproductive parts.
Right.
So what are like the most common symptoms you see people walk into the clinic with?
Well, the classic symptoms are painful periods, and that's
Which,
the one.
how do you quantify whose period's more painful than someone else's?
That is boy, you just drill down into the heart of the matter. But,
Yeah.
a lot. It's sort of like heavy menstrual bleeding, which is you can say, well, there's some there is some definition to like what is heavy bleeding versus normal bleeding, and so there have been times when they've tried to quantify what pelvic pain is or painful periods, but really the way I look at it is it's subjective. If you have periods that are painful enough that they interfere with your ability to do what you want to do, and that's one of the first questions I ask.
Yeah.
Because most women have some discomfort with their periods, some cramping, and that's what the uterus does. It's a muscle. It cramps, it contracts, and that very process can be uncomfortable, and it's trying to expel blood.
I love that you're explaining that process can be uncomfortable.
Yeah, do you like that?
Yeah,
Like-
I know. Thank you.
I'm a woman in a man's body.
Yeah,
That's
you're
what I
just
keep saying.
mansplaining uterine pain to us.
Yeah, really. Just
Cool.
listen, Britt. Just listen for a second. Will you? Just listen and learn. Listen and learn.
Okay,
So,
let me jump in here
now
because
I know where we went.
I think
What's
so tricky about this is when you're a young girl, and
Right.
I just want to say too that as we're talking, we use a very inclusive definition of women
Thank you. I
and
realize I've done
female,
that.
and it's difficult when you're talking about a gynecological disease that has to do with very gendered
Right.
organs.
Yes.
But we want to be as inclusive as possible, so we will have conversations about transgender and non-binary individuals.
Exactly.
But people with periods. So when you're
Okay,
a young
thank
person
you.
with a
I'm trying to
period,
learn, Britt. I'm trying to learn.
it's all right. That's what I'm here for.
Yeah.
When you're a young person starting your period, your mom says to you, legit, all periods are painful.
Right.
Everyone has this pain. It's normal. Suck it up. Be strong. And you're like, whoa, this sucks.
Yeah.
But that's how you internalize it.
Right.
And so I think I always try to say, because we've been to several conferences and stuff, I always try to say, are you missing school?
Yeah. Right.
Or
Yep.
are you missing work?
Yep.
Are you saying no to friends? Like, it's kind of like symptoms of mental health issues, right? Does your
Yeah.
lifestyle change because something's going on in your mind or your brain or how you're feeling? Is your lifestyle changed by, certain times of the
Yeah.
month
Yeah.
or what's happening inside your body? Then you might not have a normal period.
Right. And I think you kind of drill down on one of the tragedies of this condition, which is that it doesn't. Oftentimes you'll see it in families. There's a hereditary component to it, but oftentimes or many times, the other women in the family may not have symptoms to the same degree as the young woman who's starting to have her period, and so they start to, for good reason, just because of their own experience, start to think that she's maybe exaggerating her symptoms.
Sure.
And
much love to teenagers, but I was a teenage girl at one point in time, and I think a lot of things were exaggerated when I was 13 or 14. Sure. So it can be hard, I think, as a parent to quantify that.
And that's exactly. So it's just one of these things where what we're trying to do, Britt, with this show is to try to increase awareness and sensitivity to this condition, so that to try at least in one of our goals, I'm speaking for both of us here, but
I'm on board.
Tell me, is just to try to decrease the isolation and so that we can maybe help lessen that, what I think is of a tragedy, which is a young woman, a young person with periods.
There you go.
An adolescent who is having symptoms that perhaps are not being interpreted by others correctly.
Yeah, and I think with this episode in particular, I really want to demystify endometriosis. And I mean, let's get this straight. It's a chronic condition, right, which we didn't touch on. There is no cure, and that can be pretty scary. Yeah. But I think if you listen to these symptoms and you're listening to this information about the disease, and then at the end we're going to make sure we don't leave you hanging and we give you some resources, you can live well with endo. Is like the overall statement I want to make about that. Yeah. So painful periods, I would agree. You said heavy menstrual bleeding.
They can be heavy menstrual bleeding. Those are the big...
More symptoms.
And again, as we were talking about severity, it's different for everybody, but their interpretation, if and you mentioned this too, does it affect your ability to do what you want to do? Do you have to miss events? Do you need to miss school? Do you need to miss work? Heavy menstrual bleeding. And then you go into some of the... down the list, which can be painful sex is almost another one of the more common symptoms.
Right.
And then painful bowel movements, painful urination, pain. And then there's a lot of different, what we call, just to make this sound like I know what I'm talking about, comorbidities. Because when you say that...
Okay, what's a comorbidity?
See, there you go. See, now
it reminds me of death. Now we're really scaring people.
Well, it just means associated with other things outside of the condition itself. So endometriosis is associated with a very slightly increased risk of ovarian cancer.
Yep.
It appears to be associated with, and it's kind of hard to nail this down, other autoimmune conditions. There's immune aspect to it. Fatigue.
Yep.
So, a lot of times in bowel symptoms that a lot of times people, they get, many people are diagnosed with irritable bowel syndrome, which you can have endo and irritable bowel syndrome, but a lot of times it may be more endometriosis than IBS. So, and that's what I mean by comorbidities, is that there are other things that go along with the condition oftentimes that are not just the condition itself.
Yeah, and I think that it's important to say, not everybody starts experiencing endo the same way, and endo shows up differently in so many different people's lives.
Exactly.
I know for me personally, it started when I was in high school, and I didn't get my period until I was almost 16, which now I feel like is really late. And I had all those same common symptoms, but I know, friends of mine now who are going through infertility who work with a specialist and have surgery and find that they have endo, but they've had no pain with sex. And it wasn't until they started to try and get pregnant that they realized they couldn't because their tubes are blocked by, is that ectopic endometriosis?
Well, it's just endometriosis.
Okay, sure. So I think that that's also really tricky with the disease.
That's why I think it's important to just don't limit the definition or the symptomatology of endometriosis to a few things. You got to
Sure.
look at the picture. And that's, and we've talked
Yeah.
about this, Britt, about just how, some people think that, doctors or providers will say, oh, you're too young to have these symptoms or you're too old. And you
I
got to
hate when anyone tells me I'm too anything.
yeah, right, exactly. So you got to look at the picture. You got to, and this, you got to take a little time to just sort of say, I wonder if this could be that. Even though they may not have pain with intercourse, they may not have pain at all,
Right.
which is frightening. I've operated surgically on people and looked in there and found stage 4 severe endometriosis, and they have very little pain.
We'll help you identify what that is in a little bit.
It's really
Ugh.
it's very mysterious in many ways.
Okay, so speaking of not being too young or too old, tell me, most commonly, when do you see people first present with endometriosis?
Well, when I see somebody, usually by the time I've seen somebody, they've had it for a long time.
Yeah.
So and that there's oftentimes it's been kind of by research shown that it takes oftentimes almost 7 years to get a correct diagnosis.
Yeah, I think they say average 7 to 10 or something.
Yeah. And so by the time I've seen somebody, usually they've been operated on or they've had symptoms for a long time, and then they're coming to see what else we can do. But for many younger people with periods, they start to notice the symptoms when they start getting their period.
Sure.
But not everybody.
Yeah.
And so and it can start out brutal, meaning they get their period and they're on the floor and the fetal can wham, or it can just creep up. And so there's no absolute start date. But usually when people look back, they say, oh yeah, I've had these symptoms since shortly after I got my period, or perhaps when right from the onset.
So you can't be too young. I mean, these days
you can't be too young.
People are getting their periods so young.
Yeah.
10, 11 years old.
Yep.
And your body is going through so many changes. And again, you can't quantify what's a painful period because you've never had one before.
Right. And it's not something usually that families sit around and talk about over, roast chicken.
Families
to the side
don't.
of broccoli.
And you also don't, like, when you're hanging out with your friend and you're putting your favorite nail polish on your toes, you're not like, hey, do you bleed and are you in pain? Like, That's not where the conversation goes.
I can only imagine. Yeah. Exactly.
You know what I mean.
Yeah.
Even though he's like, I have no idea what you're talking about.
Well, as
When
a
you're like
human being,
playing
I can
with your Barbies and you're like, does your period hurt?
Yeah.
That would be a great commercial. We should do that. Because we could teach people how to talk about their periods.
That's right.
Okay.
That would be a great service to decrease the isolation.
Yeah. So I think, what's tricky about thinking about when it affects people is, and same with the symptoms, depending on where you are and what stage you might be in, your symptoms might be different.
Exactly. You can't determine stage from symptoms. You can have, a lot of times you'll find that sometimes with people with more severe symptoms, may have an earlier stage, a more mild, supposedly mild category.
So let's go to the end, because we started when we're talking about age and kind of when you start to notice patients that might have endo or when the patient might notice themselves. Let's go to the end of that. So we started with periods, but now let's talk about on the other end when you're premenopausal, postmenopausal. What might those symptoms look like, right? It's probably not heavy, really painful periods, is it all the time?
Well, that's not a super common group of people, but
Sure.
And so it would be the same. They're probably not going to bleed because and we're talking about a person with periods who has gone through either surgical or just natural menopause, and during that time, estrogen levels go down, and endometriosis is an estrogen sensitive condition, and so the fuel, estrogen is like the fuel on the fire, right? And so if you can, at that time, estrogen levels go down. And for many women, if they've had people with periods, pardon me.
You're good.
They may notice their symptoms improve or go away. And that does happen. But for some people, it doesn't. And so, and the reason for that is what we were talking about a little bit earlier, is that some endometriosis appears to have the ability to produce its own fuel.
Mm-hmm.
And so that's where I think some of the complications with diagnosing people stem from who are older, because people, providers will say, well, you can't have that.
Right.
Yeah, you're menopausal. You can't. It doesn't exist, and it goes
You're
back to
too old.
You're too old, and it's that's due to probably the aromatase, or endometriosis also causes other things besides just the disease itself.
Right.
It's not just the endometriosis lesions, the endometrium-like lesions that are elsewhere in the abdomen. They cause nerve growth, they cause inflammation, they cause adhesions, which are scars.
Mm-hmm.
So just like you can get a scar anywhere else on your body on the outside, you can get scarring on the inside. So when you have tissue in the inside of your body that is inflamed or irritated and are in close proximity, they can start to stick together like glue. And so even though you may be menopausal, meaning your estrogen levels are have gone down to virtually zero, and you may not have endometriosis implants that are stimulated,
Mm-hmm.
you may still have the cement in your pelvis or the glue in your pelvis that is pulling something else to something else and causing symptoms.
Okay, so there are 4 known stages,
Mm-hmm.
and you were talking about how the stage of the disease isn't necessarily indicated by the symptoms or pain.
Right.
So let's just go over the stages so everyone understands them. What would you consider like a stage 1 case? What would that look like?
Well, stage 1 or 2, which kind of, again, there are different ways of describing minimal and mild endometriosis. That staging, by the way, was designed by the American Society of Reproductive Medicine, and it reflects a person's ability to become pregnant with these stages.
Oh, interesting. I didn't
so
know
it
that.
doesn't have anything to do with pain.
Right.
And so that's why, the staging doesn't necessarily reflect the symptoms that the patient is having. So, but usually stage 1 or 2 is superficial endometriosis lesions on what we call the peritoneum, which is the skin of the inside of the pelvis.
So not a lot.
Thank you. Yeah, not a lot. Not a lot. But actually, you can have a huge amount of surface area and still be like a stage 2.
Okay.
But when you start getting to stage 3 and 4, you're talking about depth of invasion. So
hold on. So the peritoneum, let's get into the anatomy really quick because I'm a very big picture person.
Yeah.
The peritoneum is kind of like, I almost think of it like a sac that holds your reproductive organs.
Yes.
So what is
not just the reproductive organ? It covers the whole inside of the pelvis.
See, this is good. I didn't know
all the way over your.
So tell me what organs are in there.
Well, so in the abdomen and pelvis, you're talking about. Okay, I better be careful here. I really will sound.
We can always issue a retraction.
Yeah. There's always the gizzard. No, there's the liver.
Okay.
There's the spleen. There's obviously the kidneys and the bowel and the stomach, large bowel, small bowel, and then you get down into the pelvis. So you're talking about the uterus, fallopian tubes, ovaries, bladder, and rectum.
Okay.
And that it is exactly like if you took the inside of. Literally, you could, and that's I think a pretty good description. Let's just say that you are under anesthesia.
Yeah.
And when you are having a laparoscopy or minimally invasive procedure,
it's surgery.
Surgery, yeah, exactly. Yep. You need to inflate the belly like a balloon.
Yeah.
Well, so that gives you space to move around and do what you need to do. But just imagine if you have this kind of open cavity into which. Or that's where you find the organs we were just talking about. Well, just imagine if you were to make a little incision and throw a little balloon in there and blow it up. That balloon would expand and kind of cover. Does that make any sense?
Yeah.
Kind of fill the space available, and that's what the peritoneum is like. It's like this balloon,
and it's below the diaphragm.
It's
the
on
lungs,
top,
or they touch.
Well, again, it's just it is a lining. It's as thin as plastic wrap.
That's a really good visual.
And translucent like plastic wrap.
Oh.
And so you can, in somebody who does not have endometriosis, you can lift it up and it's as thin as, like plastic wrap, and and you can see through it, and it just lifts up, and it's very delicate, but it covers everything. So, it covers not really the uterus so much, but everything around it, all the side walls, and then going up around over the diaphragm, and so that's where endometriosis tends to implant, is that that lining. But yeah, all the way up, the diaphragm is the muscular separation between the lungs, or the chest cavity, and the abdominal cavity, but that's got peritoneum on it too.
Okay.
And so I wonder what now I'm asking, what is the purpose of peritoneum?
Well, I mean, you don't have to
It
answer
lubricates
all the questions.
It lubricates everything. Believe it or not, lubrication is important.
That is not this episode, Doctor.
Well, we don't want we want our bowels and everything to be kind of like wet spaghetti, right? It just kind of rolls over everything. Everything just kind of, it's like seals on the beach, right? They're just kind of rolling over each other and slapping their little fins together like that.
This was not part of the plan. I don't know where we're going with this.
I think I've answered the question.
But here's what I'm thinking with wet spaghetti, and
if it was dry, it'd be dried spaghetti after it's
right,
cooked, and that's what adhesions do.
That's exactly where I was going.
I could tell it.
Yeah, because, okay, so you've got endo, stage 1 or 2. It's growing on the peritoneum. It's creating these lesions, as you call them.
Right.
And
spots, little.
Yeah, and we'll get into that in another episode. This is just Endo 101.
Yeah.
But what does a stage 3, 4 look like? Because I was a stage 3.
I think that's correct. Well, that you start to usually see in the more severe stages, stage 3 and 4, what we call depth of invasion. Meaning it's not just necessarily.
Wait a minute. Depth of invasion.
Meaning, okay, think about this. Okay, I'm winging this here, Brett. I'm winging.
Sounds like a Star Wars thing.
Yes, exactly. Put up your shield to protect against the depth of invasion. And so, but imagine like grass and dirt underneath. If grass is the peritoneum, the dirt underneath would be deep invasion. So, a weed. Ooh, we could go into adenomyosis here too, Brett.
No, we're not. We're on Endo 101.
I know. I'm with you.
With me.
So the grass is like that, that superficial layer, and then below that. And when you start seeing endometriosis digging through that superficial layer deeper, that is, we start to get into the higher stages. And then especially when you get ovarian endometriomas and the size of those. So an endometrioma is an endometriosis cyst on the ovary.
Okay.
And so,
but cysts on ovaries are common.
That's right.
And not all cysts on ovaries are endometriomas. So
Correct.
don't just assume because you've had a cyst on your ovary that you have endometriosis.
Yeah. The ovaries only do 2 things, and I'm not gonna, but they make hormone. Well, they do 3 things. They make hormones.
They're really important. Don't minimize their importance.
No, they're hugely important. It's like saying, all
ovaries
Mick Jagger
only do 2 things.
The Mick Jagger, for those of you who know, can only sing.
No, there's a whole song about his moves.
Yeah, right, exactly. So, no, but they make hormones, they make cysts, and they cause problems.
Yeah.
That's for some people.
They also help regulate your hormones. And
right. Yeah, but so that's what I meant when they make hormones. But if you were to do an ultrasound on a person with periods who wasn't on any hormonal suppression, meaning birth control pills or anything like that, you would, if you did an ultrasound of that person every day of her life for 3 months, you'd find there was a cyst on one ovary or the other at least 50% of the time.
Yeah.
It's normal. And so you got to differentiate between abnormal and normal.
Okay, so you would say the presence of endometriomas, though, would maybe cause you to think a person is in stage 3?
And there's this whole kind of mathematical point-based system that says, okay, well, as depending on the size of the endometrioma,
okay,
like a little teeny superficial one, if there was, wouldn't really necessarily bump you into a higher stage. But so the size of the endometriomas, how many there are, if they're on one side or the other side, adhesions, so scarring. So if there's a bunch of scarring on the fallopian tube or tubes or ovary or ovaries, can bump you into a higher stage. And so you start just talking about, more and deeper.
So Dr. Google, because you're probably not the only doctor people who listen to this podcast are referring themselves to. Yeah. But Dr. Google talks a lot about DIE, or deep infiltrative endometriosis.
Yeah.
And is that kind of what you're referring to when you're talking about the infiltration of the disease and how it can grow into organs and things?
Yes. And so, but DIE, deep invasive endometriosis, is it's got these things are, I suppose if I did a literature search on this, where did somebody come up with that arbitrary line? Is like deeper than 5 millimeter invasion somewhat.
Okay.
And so, but if it's, again, that peritoneum is like plastic wrap, and that's just, there has hardly any, thickness to it at all. So if it's invaded deeper in there, but it's not deeper than 5 millimeters or so.
But it doesn't just have to invade the peritoneum. It could be invading your bowel or your rectum or your uterus. Or
exactly. And ovary. So, but that's where it kind of goes into the staging. Like you would say, like, let's say that you had an endometriosis nodule or something on your small bowel. Well, but the endometriosis in your pelvis was, if you just look down there, and you calculate the point structure and this and that and this and that, that maybe it's a stage 2, you would say stage 2, and then you put an addendum on the small bowel. So that's where it gets, which is
an addendum, as in like, well, it's worse here.
Yeah, well, that you're finding it, it's a stage 2 because of the way it's categorized, but we also found it on the diaphragm.
Okay. So
it's just kind of like an additional bit of information, but that doesn't really factor into the point calculation. That's also kind of, a lot of people have trouble with that, with stage 1, 2, 3, 4, because it doesn't reflect pain, and it's not good at reflecting endometriosis elsewhere, like on the bowel or diaphragm or that sort of thing. And, from a fertility standpoint, it can be helpful, but, that doesn't really, for many people, it's not very satisfying when they're in excruciating pain. Oh, you have stage 1. Yeah, it doesn't.
Yeah,
they
you.
Feel, they kind of feel bad, and so I spent a fair amount of time kind of trying to say, this doesn't have a necessarily. It's not a relationship between stage and pain.
No, and I think a lot of times too, in our nonprofit, we work with a lot of people, and they'll say, "Well, I don't have a ton of pain anymore." And I think that's because as we're talking about this disease, it progresses and it changes. So your symptoms might start out as painful periods and heavy bleeding. But if you're living with this disease, so this was my case. So this example is very anecdotal. But I lived with this, and then I went on birth control, and I had some ovarian cyst issues in college. And then it was kind of a level set. And until I went off the birth control, a lot of the pain and stuff didn't come back.
Yeah.
And I think part of that's because I was changing stages, as it were, with my endo. And my endo was evolving. And then when I finally had surgery, it was stage 3 because it was pretty much everywhere. And I didn't have some of those earlier pains. My symptoms had evolved. They were different. I was having bowel issues, pain with sex, and I think that's important. So, just because you don't have the pain with your period right now doesn't mean that it is an endo. Right. And you could have progressed so that, your body also tries to protect itself. And that's also where I think adhesions come into play, and where you get that frozen pelvis and you need the pelvic physical floor therapy. Because your body is saying, okay, you're in all this pain. What can we do to support you? So it kind of builds like a fortress around you, and it creates the frozen pelvis is really your body's reaction to all your pain and inflammation and trying to support you. Yeah. And that's why it reminds me of an autoimmune disease in that way, because it's kind of attacking itself.
Yeah, exactly. Yeah. Yep, I agree.
So, that was really good. I feel like I learned a lot.
Well, thank
good
you.
work.
That's very kind of you. It's a pleasure to talk about this stuff. It's really, it's fun to kind of share the energy.
So I don't want to leave people hanging. I want to make sure if you're identifying with these symptoms, or you have a loved one that, might have brought in some of this stuff up with you in the past, hopefully you are talking about your period, number one. Let's just put that out there. Everyone should be talking about their period. But where do you think, as a doctor, as an expert, where would you send people for more information?
Well, I think, there's a lot of regional or state-based support groups that can be helpful, like here in Minnesota, Endo Warriors.
Yeah, the Minnesota Endo Warriors. That's my nonprofit.
Yeah. Oh, is it? I didn't realize it. And which is a great organization, by the way. But on a more kind of national or even international level, things like the Endometriosis Foundation or Center for Endometriosis Care, and there are others too. But Nancy's Nook on Facebook is probably the biggest in the world.
Yeah, so let's reference people how to get there. So if you are on Facebook, number one, I know social media can be toxic, and if you're struggling with a chronic disease, it can be really hard to watch everyone's highlight reel. But I would suggest going on Facebook, and it's Nancy's Endometriosis Education Nook is the name of the group. She's got right now just under 70,000 members.
It's astonishing.
It's amazing. And it is truly a resource for educating yourself. So don't go in there and expect to lament about your pain, because you'll probably be sad that you can't do that there.
Right.
This is a place for you to educate yourself. She's got a ton of articles and research, and lots of doctors like yourself are in there.
Yep.
And she's got the coveted list.
The
I think
list,
we need some music when I say the list.
I know, Nancy's list. And just for people who are wondering, who's this Nancy? But Nancy Peterson was the nurse of Dr. David Redwine, who's kind of considered one of the grandfathers of
The pioneer.
Yeah, pioneer. I shouldn't say grandfather. It probably would not be.
He's not that old.
He's not that old, and he's still vigorously and enthusiastically involved in endometriosis, etc. But he really kind of started the whole. The surgical aspect, or was one of the people who really started to develop that surgical aspect of excision, et cetera, for treating and understanding endometriosis. And Nancy worked with him for decades. And after he retired and she retired, and I think maybe even before he retired, she started this support group. And when I got to know Nancy, there were like 7,000 people on there.
Wow.
Yeah. And it's just grown exponentially. And so I would imagine, I'm almost sure that this is the biggest endometriosis support group in the world.
I would agree. I don't think they consider themselves a support group. They consider themselves an educational resource.
Yeah, maybe a better way to
But I'm on board with what you're saying. I also, one thing we didn't articulate yet that I think is really important is, number one, you can't properly be diagnosed, correct me if I'm wrong, with endometriosis without surgery.
Yeah, that's generally considered true. And the reason I'm kind of hesitating is that there are certain things that you can see, for example, on an ultrasound that would be almost certainly endometriosis. But you can't really diagnose it, that way. You can just say this is all these things.
I mean, we'll get more into, what a true expert is and why they're an expert. Yeah. But I think you, sir, as an excision endometriosis expert, can probably diagnose endometriosis off of an ultrasound in some cases, or in some cases off of an MRI. But I just have to tell you, and I know this from personal experience, and I know you know this from seeing patients who've come from other doctors, that not all doctors are the same, and not the education that you receive. I mean, you have to cover everything from ovarian cancer to having babies. Right. There's not a ton of time in there for endometriosis, even though it affects 1 in 10 people with periods. Right. We need to make more time is what I'm saying.
Yep.
But I think that if you're going to your regular gynecologist and they see one cyst on your ovary and they tell you that you have endometriosis, get a second, third, fourth opinion. And then the other thing I want to say is not all surgery is created the same. So while I'm telling you to get a proper diagnosis, you need to have surgery. The surgery we're talking about here, even though it's laparoscopic, meaning keyhole, right, and minimally invasive, it still is major abdominal surgery. I mean, you're going under anesthesia, so you're out, right? That's scary enough for most people. It was for me. And two, would you like to go under and have someone poke around in there just to close you back up and tell you you have something? Or do you want them to utilize the time when they're in there to remove the disease and maybe help you feel better and diagnose where it exists? And if your fallopian tubes are clear, like, it's kind of, I don't know, if you're doing housework, for example, do you want to just open your attic and see that you've got a mold mildew issue, or do you want someone to get in there and remediate it? Yeah. Because for me, all I'm hearing is it's going to cost, with insurance or whatnot, maybe like $15,000 just to do it either way.
Yeah.
So I would rather you take care of the disease. So that's why I feel very strongly that people shouldn't just have surgery with anyone.
Yeah.
That if you're headed down that path and you really think this is where you are going and endo is on your list, don't be afraid to seek out an expert. That's what the list is. Nancy's Nook's list is experts in excision.
Yeah.
Seek one of them out. I know Dr. Hegard's on there. That's how we connected.
Yep.
And you'll get the right treatment. You can always go back to that other wonderful gynecologist who held your hand and helped you through other things. Like, I know it's a very intimate relationship, but this is your health you're talking about here, and it's okay to say, no, I need a person who's an expert on this.
Yeah, I think, and that comes to a point that I think, you bring forth a lot, which is the idea of advocating for yourself.
Yeah.
And just because, most doctors, most surgeons oftentimes have things that they do more than others. And so your surgeon may be superb, but maybe in this particular area they don't have quite as much experience. And so the fact that I think if your doctor's confident and is not totally ego driven, to have a patient say, you know what, I feel like I want to see somebody else to at least address this. I think that a confident doctor will say, great, I'd love to get somebody else's view on this.
Right.
I value somebody else's opinion. And if you feel like you can get better care, do it. And that would be, I think that's a sign of the doctor you want to stay with.
I agree.
And the fact that you're seeing somebody else does not necessarily mean you're trying to, minimize or trivialize the skill of the doctor you're seeing. And so, I think you shouldn't be embarrassed to look for another opinion. We work for the patient, not the other way around. And
my girlfriend called me, and I love when people do this. I feel like I've become the endo advocate in my own little circle. And she was saying,
it's a big circle.
Well, you're wonderful. My doctor says she can get me in next week for this surgery just to diagnose it laparoscopically. And I did one of those, like, this is when I'm telling you this and I'm on my pulpit, friends, I'm putting my arm around you and I'm giving you a hug and I'm saying, listen, do whatever you want, do what's right for you, but you're my friend and I don't want you to just have surgery with that person who said they could get you in. Because guess what? The people who are experts at this do it almost every day, all day long. They see 10 plus cases a week. Mm-hmm. And if you have any other disease or any other, if you have cancer of a certain area, you're going to see that cancer specialist. You're not just going to see your primary care doctor.
Right.
If you have a heart condition, you're going to see someone who specializes in that cardiac issue.
Yeah.
Same with endometriosis. It's worth it. It's worth it.
Yeah,
I'm done. I just had to give them that emotional hug and push them out into the world to get the right resource.
Well, can I just make a little addendum on that?
Okay.
That I love that you bring this up because this is the nuanced aspect of caring for people, I think, in general. Let's say, like, if you live in a metro area where there's a lot of doctors, a lot of surgeons, and some specialists, it's easy to go 15, 20 minutes, a half an hour to see somebody who's more specialized. If you live 5 hours, we're talking to you from the listeners here from Minnesota.
Yeah, right? In the Twin Cities.
If you are up in Ely, Minnesota, which is 5 hours away, it may not be, it's not an easy, well, I'll just kind of go jump in to see somebody. And so I don't think for most people, like a diagnostic laparoscopy it's not a terribly risky procedure. And for some people, it may be reasonable to have somebody to go in and look and see what they see. And to be able to bring that information, 6 hours to see whatever specialist. All right, I know we could agree. You tell me you think I'm full of hot air, Britt.
I do.
Okay.
Here's why. I'm sorry. I'm sorry, Dr. Hegard, but I just have to say, like we said, not all doctors are created equal. And I think, what's worse than waking up and being told you have endometriosis?
It's being told you don't.
Correct.
All right. Yeah, I see that.
And if they're not a specialist and they can't see, and we're going to talk about what the different types of disease look like.
You're right.
And
you're right. I agree.
Okay. So retract what you.
Okay. Well. Okay. I'm not going to necessarily retract it.
Okay.
But how about this? Can we agree on this? That if for some reason you do decide to have surgery, have that surgeon take a ton of pictures.
There you go.
Close-up pictures, because I know where you were going, which is it can be hard to identify these endometriosis spots. They don't all look alike.
Yeah.
And so even people who do a lot of surgery may not recognize, that's what that's not necessarily a scar, that's endometriosis. And so if you advocate for yourself, if you're going to go into surgery somewhere, just make sure they just take a lot of close, detailed pictures of the pelvis on either side of the rectum, deep in the deep pelvis, the ovaries on the pelvic sidewall, beneath the ovaries, the uterus, the area over the bladder. Because people who do a lot of this, I can look at those pictures and go, that's endo.
Yeah.
And so if, it would be great if everybody could come and have surgery with somebody who does a lot of it. I am in complete agreement with that. But if you can't do that, at least bring us the information that we can say, I think that's it.
Yes, I agree.
Would you buy in that much?
Yes.
Okay.
I'm on board. Good caveat. Cool. Right. I don't know. I feel like that was pretty good for Endo 101.
I know.
Anything we missed from your perspective?
There's a lot we didn't
I
cover.
know.
That's why it's a series of shows.
That's
not
why
just
we have
one.
our own show, man.
That's right. Right.
Awesome.
Britt, it was such a pleasure to talk with you about this.
Aww.
It's really a joy.
Thanks.
And to have this kind of, I think, symbiotic kind of energy talking about this condition, which we both care so much about.
For sure. Awesome. Thanks so much.
All right.
Thanks so much for listening. Be sure to connect with us on Facebook at facebook.com/The Endocast. Our theme song is Renegade Energy by Tacky Annie. This is a Matriarch digital media production. Learn more about Matriarch and check out all their great podcasts at matriarchdm.com.
My body,